Thank you, Marcia. The 2018 National Academy of Sciences Public Welfare Medal is awarded to Paul Farmer, physician, anthropologist, and humanitarian. He is currently the, I already forgot the pronunciation, Colocatronis University Professor of Global Health and Social Medicine, Chair of the Department of Global Health and Social Medicine at Harvard Medical School, and Chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. The Public Welfare Medal, which was established in 1914, is the highest honor of the National Academy of Sciences and is presented annually by the Council of the Academy in recognition of distinguished contributions in the application of science to the public welfare. The citation for Paul Farmer reads as follows: for pioneering, enduring, community-based treatment strategies that demonstrate the delivery of high-quality health care in resource-poor settings in the U.S. and other countries. And just to explain, because this is our biggest award, I'm given a little extra time for a deeper introduction, and Paul Farmer has extra time to make some meaningful remarks. So, I'll begin with a short biography. Paul Farmer was born in North Adams, Massachusetts, as one of 6 children of a salesman and a high school teacher. The family moved to Weeki Wachee, Florida, where he had an unconventional childhood, spending a significant part of it in an old school bus that his father had converted into a mobile home. Farmer attended Duke University in 1982, where he received a Bachelor of Arts degree in medical anthropology. His lifelong pursuit of providing health care to some of the world's poorest people began at Duke, where he met many migrant farmers, workers from Haiti, who were harvesting tobacco in fields not far from the campus. He became interested in their lives and read about Haiti's history and culture and studied the Creole language, beginning a lifetime of involvement with that country. From one of his letters of support, the early connection to Haiti is at the core of his passion for helping the world's poorest and most vulnerable. He went on to Harvard University, earning both an MD and a PhD in medical anthropology, again from a letter of support. This allowed him to combine an understanding of culture, society, and people with his knowledge of clinical medicine that became the basis of his future work. While volunteering in Haiti as a medical student, he was appalled by the lack of health care he witnessed. And in 1987, he co-founded Partners in Health with fellow physician Jim Young Kim, who now leads the World Bank, and activist Ophelia Dahl, the daughter of author Roald Dahl and actress Patricia Neal. At the time, HIV/AIDS and multi-drug resistant tuberculosis were rampant in Haiti, and many public health experts were deeply skeptical about whether it was possible to provide quality health care in a country with so many challenges and so few resources. Farmer and his colleagues developed novel community-based treatment strategies that demonstrated that these and other common diseases can be treated appropriately in resource-poor settings. He also played an important role in mobilizing funding to pay for these therapies. Partners in Health's innovative model of community-based care delivery and providing access to world-class medicines has saved countless lives and is now being duplicated around the world. More recently, in the wake of the devastating 2014 Ebola outbreak in West Africa, Farmer and Partners in Health initiated healthcare programs in Sierra Leone and Liberia. Additionally, Partners in Health recently launched the University of Global Health Equity, a new health sciences institution in rural Rwanda to train the next generation of African health professionals and global healthcare leaders. As a widely recognized international health expert, Farmer has been featured in numerous news stories, including a best-selling 2002 book, Mountains Beyond Mountains by Tracy Kidder, and a critically acclaimed documentary film released last year, Bending the Arc, with the subheading, "The arc of the moral universe is long, but it bends towards justice. They bent it faster." The documentary can be viewed in this auditorium on June 5th from 3:30 to 6:15 in an event sponsored by the National Academy of Medicine. In his letter of support, the author of Mountains Beyond Mountains, Tracy Kidder, wrote, "Farmer and his colleagues have offered the world vivid proofs that the entire range of human ailments can be successfully and economically treated in some of the most difficult settings imaginable, in places like Haiti and Liberia, in the slums of Lima, and the prisons of Siberia." Farmer himself has authored numerous books and articles and is a recipient of many awards and honors, including the Margaret Mead Award from the Society of Applied Anthropology, the Conrad N. Hilton Humanitarian Prize for Partners in Health, and the S. Roger Horchow Award for Greatest Public Service by a Private Citizen. He is a member of the National Academy of Medicine and the American Academy of Arts and Sciences. And I wanted to end with a quote from one of his letter writers, which I think really sums up his nomination package. Paul Farmer started his career as a student, seeking to understand and heal individuals whose circumstances kept them from accessing what could only be described to them as the miracles of modern medicine. Today, he still seeks to understand and heal, only his patients are countries and societies. He has not sought the many honors that have been bestowed on him for service to society. I can think of no more worthy, more deserving, and perhaps more reluctant recipient of the National Academy of Sciences' most important recognition than Paul Farmer.
Thank you so much, Sue. Hearing about the prizes and papers is a humbling reminder of the richness and diversity of science today. And I've never, to Sue's point, I've never felt less ambivalent about being singled out for collective work or more honored. This is a proper nerd fest, and I feel right at home. I started medical school in 1984 as medicine was becoming, in Lewis Thomas's phrase, the youngest science. My father had just died suddenly at 49 years old. He was playing basketball with one of my brothers. My mother, on the other hand, is hale and hearty and sitting right here with several of her children. But his death led us to wonder what difference ready access to regular primary care might have made. It wasn't the first time, of course, that I had asked myself that question. I was headed to Boston after a year in rural Haiti and had no doubt that serving as a doctor in a clinical desert would save lives, as long as one had access to the tools of the trade. Whether one considers preventives like vaccines, diagnostics, or therapeutics, these tools were coming from basic science. No one at Harvard Medical School doubted that. Least of all someone who'd had an early and personal glimpse of what it meant to live in places where the fruits of discovery science are absent or unevenly shared. That meant, in 1984, as now, not only Haiti, but also parts of this country. Some of the clinical deserts here aren't too far from our great national treasures, which include research universities and the National Institutes for Health. Although I'd never heard of Ebola and HIV, the name of my comments is The Tale of Two Viruses, which is a lot easier than many of the titles of the papers we heard today. I knew, even though I'd not heard of these diseases, that I wanted to be a physician anthropologist. And this is a good chance to do what many others have, which is to thank mentors. And even as an undergraduate, I had a terrific set of mentors, including a medical anthropologist named Atwood Gaines and Arthur Kleinman at Harvard, who he likes to say that I'm now his boss, which is technically true, since As a new epidemic ramped up an old one, Haiti was often in the U.S. news, where we read about superstitious and backwards people who rejected modern medical care. But none was then on offer. And we were watching young people die of AIDS, but also of eminently treatable tuberculosis. No one in the clinical desert doubted the potential contribution of medicine and of caregiving. If there's a similar utility to medical anthropology, it's to challenge claims like that and confident claims of causality about why afflictions, all afflictions, strike some and spare others. That can't be done without careful exploration of social context, which isn't possible without rescuing more than a bit of history from the dustbin. In the affluent world, and after the great leap forward of vaccines, the history of infectious disease has been one of steady improvement in clinical outcomes. This began even before the development of less toxic antibiotics in the mid-20th century and continues among the fortunate to this day. It's not that no infection is invariably fatal. Rabies and a couple of others almost always kill in time, but whether one lives in affluence or in poverty. But drug resistance aside, the general trend has been the same. A mix of specific antibacterial, antifungal, antiviral, etc., and non-specific interventions. The non-specific interventions are important and include supportive care and replacement therapies. These have moved together most microbes causing disease in humans from the often fatal rubric to the eminently treatable one. I have been fortunate to witness such reclassifications several times over the past 3 decades. AIDS is the most obvious example. Many critically ill patients I first cared for as a medical student in the 80s are survivors today. Some of them are now colleagues or friends rather than merely patients, but all remember when a diagnosis of AIDS was a death sentence. Today, for many, those dark days are beyond imagining, and that's because of antiretroviral therapy developed by the mid-90s. These drugs, like so many others, came from substantial investments in basic sciences. But during the decade before these treatments were shown to decrease mortality, there were, in Boston, as in Haiti, huge disparities in the course of HIV disease. That decade was, of course, the one in which I trained under Victor Zhao and other titans of academic medicine. We learned that to be transformed from people dying of AIDS to people living with HIV required making it through the awful 80s and the early 90s. That only happened for those with access to rapid diagnosis and treatment of the opportunistic infections associated with the slow but inevitable destruction of the parts of the immune system targeted by HIV. Such treatment often called for critical care and almost always required supportive care. This was the work of nurses, doctors, friends and family, community health workers, and activists who resisted the notion that some people were just too poor to treat or otherwise not worth it. They resisted, in other words, the idea that the fruits of science were not for everyone in need. If the AIDS pandemic had a height and then a decline, it's because scientists, activists, and policymakers, reaching all the way to George W. Bush, came together to launch the President's Emergency Plan for AIDS Relief. Perhaps 17 million people are alive today because of it. In some parts of Africa, including Rwanda, where we've worked, pediatric AIDS is on the way to being wiped out. This integration of prevention and care only happened tardily and partially in West Africa during the Ebola epidemic. Fast forward to the summer of 2014, which found me and several friends from Partners in Health in Sierra Leone. In addition to Ophelia Dahl, who was mentioned, I'd like to name another founder of Partners in Health, Todd McCormick, who is here, along with his wife Ann, another trustee of Partners in Health. Thank God for friends like them and friends in the scientific community. Although Ebola is a very different and much more acute affliction than HIV disease, knowledge of these general trends of the ability to move people from the rubric of untreatable to eminently treatable, knowledge of these trends might have inspired a bit of reticence among the therapeutic nihilists who populate the ranks of some echelons, or the echelons of some echelons of health policy. These naysayers have included certain policy and disease control experts focused on settings of poverty. They did not include, however, people like Tony Fauci and others pushing for an effective vaccine and therapies, and they certainly did not include my friends and family from Partners in Health. We all knew that changing the fates of the Ebola infected, moving them from the nihilistic category of untreatable to the aspirational but also more honest one of treatable, was impossible without improving the quality of supportive and critical care. That isn't possible without supporting ambitious training efforts in places like Sierra Leone and Liberia, and a more gung-ho effort to lessen the neglect of the destitute sick and to support those who seek to care for them. That requires, and I have to say, in reflecting on those years, 2014, for example, we American citizens were often not welcomed back into the country by some. And that was a sting of rejection that many of us had not felt before. Of course, knowing that so many West Africans, and indeed Africans far away from any Ebola transmission, were subjected to worse, made us remain silent. Privately, we fumed. This all requires fighting for a proper safety net that includes safe hospitals, as well as clinics focused on robust prevention and primary care. New tools, vaccines, which, by the way, thanks to commitments from the NIH and other parts of the scientific community, it now appears that there is an effective new vaccine to prevent Ebola. Same for diagnostics and treatments. These all require not only investments in basic science, but also in institutions, national institutions, in proximity to those most at risk for these and other diseases. Now, unfortunately, all of this staff stuff, space and systems, there's little evidence of it at this point in West Africa, a few years after the attention of the rest of the world settled, fitfully and fearfully, on the mortal dramas once again unfolding there. But even with the world's fearful attention turned on Ebola, mortality among the infected remained appalling. With substantial local exceptions, the case fatality rate at the close of the recent epidemic hadn't gone down at all, in spite of improved surveillance and reporting. None of the Americans who fell ill in the course of the Ebola response died, and neither did many Europeans. But most of our West African colleagues with the same diagnosis died. As short-term clinical staff and humanitarians head off to the next crisis, and at the time of this ceremony, most of them have, the region is as medically bereft as ever. It's more so if one takes note of the loss of a substantial fraction of its medical professionals, including 2 Sierra Leonean physicians I know. The biggest losses, of course, were among nurses. But all told, just to use the example from Sierra Leone, some 211 health professionals died in the course of the recent Ebola epidemic. And the majority of caregiving, as we know, does not come from health professionals in a clinical desert. How could it? It comes from family, which is another reason I'm grateful for my own. The fate of Americans and Europeans with Ebola is instructively compared to that suffered by those infected during one of the later Liberian flare-ups. In March 2015, just after its epidemic was prematurely declared over, and not for the first time. The outbreak began with a transmission chain involving 11 people. All perished. Although some reports hardly mention the case fatality rate, when the primary goal is to stop transmission only, rather than to prevent both transmission and death among the already afflicted, reports reflect such bias. Again, just as occurred during the height of the AIDS pandemic, high mortality, when mentioned at all, was sometimes blamed on strain virulence or, most often, on the ignorance and intransigence of its poorer victims. The March 2015 Ebola flare-up I mentioned has been called the St. Paul River Bridge outbreak. The week it was stuttering to its dismal end, I happened to be headed back to Monrovia. The bridge isn't far from the capital. On a clear day, it's easy to spot prior to landing at the international airport. As chance would have it, I just read of the St. Paul River. In fact, read part of this out loud to my friends Todd and Ann, who are here, in a 1938 travel memoir by Barbara Greene, the younger and far wealthier cousin of the British writer Graham Greene. Journey Without Maps, his own dark memoir about their trek across the tri-zone area where Sierra Leone, Liberia, and Guinea come together and where the Ebola epidemic was alleged to have started. His book is dedicated to her. On the eastern side of Liberia, far from any bridges, the two of them crossed the river by raft. On the day, the Greens, accustomed to walking in single file amongst an entourage of porters and at different paces, were separated. The path simply died on us, she wrote. And Ophelia, I'm sorry, can't do an upper crust English accent like yours. We were facing a thick, impenetrable wall of jungle. Although her cousin was then sick with a fever of unknown origin, Barbara Greene was, by her account, bored. Maybe that, along with the heat, explains why she was strayed from the path. But she wasn't frightened, and I quote, "I had most of the men, the money, the food, the beds, the mosquito nets, the quinine, in fact, everything. Come what may, I should be all right, but I must search for Graham," end quote. The cousins found each other, however unlikely that may have seemed in a jungle invariably billed as impenetrable. And they sat down, as one does, for a picnic on the shores of the St. Paul River. Out for adventure, Barbara was deflated. She wrote, "The saint that I had felt looked after the fools of the world was keeping too close a watch on us," end quote. The drama's happy conclusion left her feeling that nothing exciting would ever happen, for something would always guard me. Guard one like her, Greene meant. And she was able to identify what that something was. Not a saint, but extraordinary good fortune and a personal fortune that originated, she noted in reissuing her memoir decades later, in the slave-driven sugar trade that long linked Britain to both West Africa and the Caribbean. Her cousin would go on to recover rude good health before reaching the coast in a boat to take them back to civilization. The day they lost sight, I'm thinking this is cheering, by the way, from the baby, but I am winding up. The day they lost sight of each other was also the day she and her half of the entourage came across a deserted village. She wondered if some horrid disease, her words, had emptied it. How could a reader not think, "Don't leave on my account, it makes me feel good." How could a reader not think in March 2015 of the horrid disease du jour if the culprit had been a virus that wouldn't be discovered for another 40 years? Would the Green cousins have survived an encounter with it? If so, this would have been in part because, like our American colleagues stricken with Ebola, they were sharing only some of the risks faced by their companions from Sierra Leone and Liberia. Unlike their 30-odd servants, the British trekkers had mosquito nets, quinine, and treated drinking water. They also had the hope, were Graham Greene to remain gravely ill, of escaping an impenetrable jungle. His cousin wouldn't have had much difficulty finding the 1935 equivalent of $200,000. What evacuation in a biosecured jet costs, more or less, for the safe passage of each Ebola patient transported from West Africa to the United States? What might have been done in the pre-jet and pre-antibiotic era for even an affluent person sick with a febrile illness causing prolonged vomiting and diarrhea? As it transpires, there was beginning to be, by the 1930s, a lot one might do to save lives imperiled by hypovolemic shock, even when caused by infectious pathogens. This had little to do with antibiotics. There weren't yet any antivirals and few effective antibiotics of any class. But even today, whether in London or in Boston, the highest standard of care for many serious viral infections does not include antiviral drugs, as these don't yet exist for many common pathogens. In other words, even early in the antibiotic era and even in the white man's grave, there's little evidence that the non-poor face the same risks as the poor, whether we're speaking of risk of infection or of outcomes once infected. After visits to West African jungles, far less impenetrable than those described by the Green cousins, I know this to be true for me and my American colleagues, as it was for all the native-born or white Americans who fell ill with Ebola over the past few years. It was true for those who fell ill near the St. Paul River Bridge: 100% mortality versus 100% survival. There are, of course, many debates about why some live and others die. It's always been thus. And informing such debates with research rather than ideology is certainly the job description of a physician anthropologist who's an infectious disease specialist. But if there can be said to be a ranking human rights challenge for discovery science and for all of us gathered here, it's this one. How do we make the fruits of science matter, especially for those who hunger for them? This honor, bestowed before my peers and friends and family by an institution I respect and admire, affords me the chance not only to thank the National Academy of Sciences and the National Academy of Medicine, but to promise to commit the rest of my years to making your work matter to more and more of those still shut out. Thank you very much.